Hello everyone. I, Dr. Manish Rai, Assistant Professor from Sancheti College of Physiotherapy, Pune, India, welcome all of you to another fabulous session at Scientifica 2021. We have the PNF man himself, Jakub Marcinski from Poland, who is IPNFA course instructor. He has pursued many postgraduate courses like PNF, Maitland, to name a few. He has been in love with PNF since 2003. So it's a long time, sir, and calls himself a PNF man, and he truly is. He has been a keynote speaker in many of the conferences and workshops. He has multiple publications in peer-reviewed national and international journals. He is going to speak to us on neurological patients approach. What tools can a PNF therapist use during work? So I'm glad to host you, the PNF man himself, that is Jakub Marzinski. Welcome you, sir, and I can't wait to hand the session over to you and listen to the session. Thank you, sir. Over to you.
Thank you, Dr. Manish, for the for saying hello. Namaste to everyone. Uh, so I have 30 minutes to talk about PNF and with neurological patients. This is a little bit like trying to travel all over India in one day. So you have to forgive me if I don't say everything because this is not possible, but I will try to show you that PNF is a really fantastic concept to work with neurological patients. Thanks to my patients who helped me with this presentation. And we have difficult times, so I would like to thank again for invitation and that I can be a part of Scientifica this year. Okay, so I live and work in Warsaw, in Poland, in Europe. As you can see, we are some hours and some kilometers away from each other, but fortunately enough, it's not enough to stop us from communicating. So, as Manish said, I am a physio since long time ago, so I tend to be old, but I still have, because of that, I have maybe nice ideas and still have some fire in me to work and to teach. Uh, First, I have met PNF in 2003, so for a while I'm working with PNF, and believe me, I'm still using it with my patients, and I'm still really successful with this. And maybe what is also important, it gives me a lot of satisfaction and a lot of fun in my work. So 50% of my patients are neurological patients. And then I can say that I work with the paid patients. Of course, I have other patients too, but 50% of them are neurological patients in the ambulatory rehabilitation center. Speaking of PNF, so we have three letters for proprioceptive neuromuscular facilitation, and it also means that people or patients or physiotherapists need fun or facilitation or fantasy. So we really, in our PNF world, think how to work with our patients, not in one way. We really try to have repetitions without the repetitions, but about this in a second. So when you think about PNF itself, it's a concept that started in the 40s. The names like Maggie Knott, Dr. Cabot or Sister Kenny, then Dorothy Voss, these are the names that are connected with the concept. And then in 1990, we have the foundation of the IPNFA, which is the organization that holds together all the teachers and assistants of the PNF. And you can see this is a nice picture of one of our AGMs, which is annual grand meetings. It was held in Warsaw a couple of years ago. And the other picture is about all the teachers and assistants from the Croatia. And this year, last year, 2020, we were supposed to meet in Japan at Okinawa, but unfortunately, because of the COVID, we were not able. Nevertheless, IPNF Online Congress was held, and maybe you could participate and see the lectures there. Okay, so PNF mainly consists of some parts. This is some part of it is general rehabilitation. We have a meds program, we have a gait, we have vital functions, we have patterns. Usually the patterns, this is the part that a lot of people talk about. Oh, PNF, so it means patterns. No, patterns are important, but just one part of the PNF concept. And we have philosophy, we have techniques, and we have basic principles and procedures. And please think about these three: philosophy, techniques, and basic principles and procedures as about the pillars of our concept. So these are always the main things that we use when we work with our patients. And we will, unfortunately, we are not able to talk about everything in our philosophy and the basic principles and techniques. But I would like to enlist, in my opinion, the most important parts and the parts that would show you how this concept looks like and show itself to you in this way. So we have a positive approach. We will describe it in 1 second. We have a functional therapy. We have the idea to treat a patient as a whole. We have the possibility to mobilize the reserves of the patient, and also the fifth huge topic of motor learning and motor control. But I just mentioned it. We will not talk about this now. Have 30 minutes. It's not enough for this simply. Then in basic principles and procedures, we have three groups. We have exteroceptive stimuli, we have proprioceptive stimuli, and in this group, we'll talk only about the resist. Only, maybe only is not the best word because this is a quite important proprioceptive stimuli, but resistance will be taken care of. And in procedures, we'll talk about irradiation and about patterns. And as you can see, there's many more that are addressed during the PNF courses. And when we'll talk about techniques, we have three groups of techniques. We have agonistic technique, we have antagonistic technique, we have relaxation techniques. And agonistic technique, we're combination of isotonics. This is one of the techniques that we will be talk about. And this is a part of agonistic technique. What does it mean in details? We'll talk in a couple slides, couple seconds. Okay, so you've seen this techniques, you've seen these basic principles, some pillars, but generally, when we see our patient, what is the most important? What do we start with? So first, we start with our philosophy. And to be honest, I cannot work with a patient without thinking of PNF philosophy. Then I would use the tools from basic principles and basic procedures. Then I will think about the techniques, and then I will think about the patterns. So it's not other way around. So the philosophy, the basic principles, and the techniques, these are really the pillars of our thinking process. So going back to the positive approach, what does it mean? Positive attitude towards the patient, it says. Okay, so this is my friend, Michael, and Michael is right side hemi. Okay, so I say, hello, Michael, as you can see, and I'm using the left hand. Why? Well, I just want him to feel safe. I don't want to start with the hemi side. I want to say hello. I want him to feel good, simply. And the patients which are smiling at you during, this is Agnieszka, nice to see Agnieszka today, and the patients that are smiling to you, this is for sure a positive attitude towards the patient, and it means that you have a good connection with your patient, and this is very important. Now you see Michael, this is some part of the therapy, and he is asked simply we are thinking about gait training, and he's asked to put his foot on the stool. Okay, so for sure, this goal is reachable for him. He is able to do it. If I would start with a too big tool, or it would turn out that he's not able to shift the weight to the one side, and then he's not able to lift the leg, so this goal would be not reachable. And if imagine that you start your training, and then it turns out that the first activity and it's a failure, it's never a good start. So try to start with goals, setting the goals for your patients that are really in their possibility to reach. Now, you see Agnieszka walking outside. Agnieszka is an adult patient with cerebral palsy. And you can see when she walks, during her stand phase, she have a medial collapse. Okay, so when we work with her gait, we want to activate, of course, the abductors and the external rotators of the lower limbs. This is one of the therapeutic goals that we have. Okay, but as you see, we don't have to start right away with our main goals. We can start with a warm-up. So we can start with easy activation of her trunk. So as an adult CP patient, she has a nice good extensors of the trunk in a good shape. So we start with concentric activity for the mass extension, so-called mass extension pattern. She is smiling. This is a nice neighborhood. It's safe. The mats are everywhere. Then I change a little bit and I make it harder for her to start with concentric work of abdominals. But again, so against the gravity, this is much harder. But then again, she can activate her extensors concentric. And this is for sure indirect beginning and positive approach. Okay, let's go more. So, speaking of indirect approaches, now, so we have in a sitting position, we are now in the sitting position, and we have Agnieszka left lower limb in a closed chain position, and she is close to that stool. Then she also has the special task, so this ball cannot go down. Okay, so she has to really control the stool with her leg. Now I'm pushing her down, so I want her extensors, abductors, and external rotators to really work. And I'm using her head and upper parts of the trunk, which are strong. So I'm using the strong part of Agnieszka to facilitate the weak part. And now you can see that this is 10 kilograms ground reaction force. But then when she reacts against my resistance, so she pushes against the scale, then you can see that the ground reaction force is 30 kilograms. So she sees the result. Okay, it's not me that make her laugh, I hope, but I hope she's simply enthusiastic about the result. And also you can see, as a PNF therapist, we should observe the whole patient. You can see that her right limb is on the ground, and then it goes up. It also means that more body weight is on the left side. Nice. Okay, PNF philosophy, this is also functional therapy. What does it mean, functional therapy? Of course, this is ICF-oriented therapy. Everybody knows ICF model. We don't have time to go through that now, but we can say that if Tomek wants to learn to go on stairs, we have to go on stairs in him, not on the playground. The playground is nice, but will not teach him how to walk on the stairs. And now you can see me trying to run with Tomek. Of course, he will not be a 100 meters champion, but for sure this is functional. Tomek is after brain injury, traumatic brain injury, and by working with his running, I have it again, we can improve his gait. So sometimes, because running is like walking, but also a little bit flying, so it's more difficult, but it's orientated on the task therapy. Okay, and please remember that being self-dependent is one of the most important goals for our patients. So we not only need to have our hands on the patient and also have the hands off the patient. This is the part of our PNF philosophy. And now Tomek has a chance to really process what we've learned before and try to do it by himself, because I will not be with him all the time. We are mobilizing the reserves in PNF. So using the scale, why not? So I can see, okay, ground reaction for 10 kilograms. Now I want 30 kilograms, so I see the result. And here you see, here you see there you go, Mr. Marek. No, this is Tomek again. Sorry for this. Marek, where are you? Okay. This always sometimes happens. Sorry for this. Okay. Now we have Marek. So Marek is a hemi patient on the left side, as you can see, and he has a problem with weight shifting to the left side, and he has a problem with walking. So one of the home program the idea was to teach him to shift the weight on the left side. He has problems with sensation of the left lower limb. So again, we can mobilize, we can show him the effect when using the scales. Okay, PNF therapist treats a patient as a whole. What does it mean? So look at Michał. I would like to ask you, what can you say about him, how he walks? And PNF therapist first looks for a good parts. So he's able to walk, he's able to walk fast, he's able to turn, he's able to walk. Nevertheless, there are the sounds around. So he's turning on the left side, he's turning on the right side. It doesn't look like he will fall. Okay, so there's a lot of good things in which you can start. Then you can concentrate on the body function and body structure level, what is not optimal and what could be better. Now, basic principles and basic procedures. So we have three groups of stimulation. We already said tactile, auditory, and the visual. So now we have part of the therapy when we teach Michael to facilitation from mid stance to terminal stance. Okay. Now I touch my patient. So I have a tactile stimulation, and this is so important. It gives so much information for my patient. There's a quite clear research about it. Okay, see, this is tactile stimulation. Yes, now, hey, this is visual stimulation. Again, tactile. So again, tactile. Nice. And I speak to him. So I use auditory stimulation. And again, look, too fast. Again, auditory stimulation. So I speak to my patient. I touch my patient. Yes, and I show my patient what he's supposed to do. Then I have his concentration. He is with me in the therapy. And exactly. Good. Now, resistance. What is resistance? So, resistance in PNF should be optimal. And please remember that me as a therapist, I can give resistance, but also, or even mainly, environment gives resistance. I sit on the chair resists on me, I resist on chair, right? Newton. The gravity itself. So if you start with your patient's abdominal workout and you start from lying on supine with a hemi patient or traumatic brain patient, he has to go over your resistance and he has to go over gravity. This is simply too much very often for our patients. So please don't forget the gravity itself. And we very much think of three muscle contractions. So static, concentric, and eccentric, of course. And our resistance is three-dimensional. And we have it through our lumbrical grip. So we touch the patient. So we have the stimuli for the patient, tactile stimuli, and we give resistance through our lumbrical grip. Okay, so now you have a TOMAC. You already met TOMAC. And what is happening here? We will stay with this slide a little bit longer. So I want to shift the weight on the right side for Tomek, because when he walks, he has a problem with weight shifting. Okay, so to make it easier for him, I gave him support for the upper limb, and he is in a half-sitting position. And I want to resist his shoulder and the pattern so-called anterior elevation, and I want to resist his upper limb and flexion, adduction, and external rotation. Okay, but I can also, you see, it's also the same position, but now, look what is happening here. So we have the gravity that pulls him down, okay? So Tomek has to work against the gravity because he was asked to go up with his hand in the direction of the ceiling, okay? So he works with flexion, adduction, external rotation, and elbow flexion, which is a PNF pattern, okay? I'm pulling him down to here. So he reacts with the increasing the ground reaction force in the lower upper limb, and he reacts with flexion, abduction, internal rotation, and maybe also some posterior elevation of the pelvis. But all of this, all my resistance is to spread the excitation to this standing leg. So I want to use irradiation, and I use for this three-dimensional muscle chain, okay? So I'm resisting other parts of the body, so we have a bigger ground reaction force on the right lower limb. Okay, so maybe we see it. So this is how we start with Tomek, okay? Yes, so first we give resistance. I use my body weight, so he has to work really hard. Good, and you can see that ground reaction force differs from 40 to 80 or even 90 kilograms. So if you multiply this by acceleration, you have a reaction force. You see that Tomek is doing some crazy things, so he's having fun, okay? So if he has positive emotions, we have a chance that he will learn that better. So, yes, Tomek, work against my resistance and work against the gravity. This is your task, my friend. Good. So, now we come to the part of the techniques. So, we will talk only about one, but quite useful. So, this is a part of agonistic techniques. And it means that they involve one muscle group, one muscle chain, and the therapist is not changing his hands. The hands stay in the same way. And we will be working concentric, eccentric, and isometric contractions. I think the most important thing is to see it. So you've already seen it, but we haven't thought about it as about a technique. So look, my distal hand, my proximal hand. So push up, concentric, eccentric, concentric against my resistance and against gravity, concentric, more adduction and external rotation, and eccentric. And all this as the indirect treatment for the stand phase on the right side. So now you have Agnieszka. The goal is the same, but I'm a little bit different position. So you have a flexion, abduction, and external rotation, and head extension, side flexion, and side rotation to the right. And I'm doing all this to have spread the excitation and irradiation to the left leg, to the left lower limb. So I lower myself, so she has to work really hard against my resistance, but not too hard, because if she works too hard, then the ball drops, the ball falls down. Okay, and you can see now I can play with this. So I increase the resistance in the end of range, and you can see that I have a nice ground reaction force for her left leg. Okay. And you can say, okay, but these patients were in a higher positions. Good. So this one is not in a higher position. So you have you imagine your neurological patient that is in the bed and he is lying down, and you're thinking, okay, so how can I influence his standing if he's not standing? Okay, so uh, we can arrange the floor here, and you can think that it looks like one leg standing. So now I will be using the upper limb, and I will ask Tomek, okay, Tomek, my friend, so reach towards the end of the mat, and I will resist the shoulder in the direction of anterior elevation, and I will guide a little bit the movement. And you can see that I'm using the better side for weak leg. So again, I'm using the strong part for the weak part. So yeah, I'm guiding a little bit now. So see, this is your movement, my friend. Yes. And now I'm giving the resistance. Okay, and you can see again what is happening. So you can see again ground reaction force is changing because of our activity. Yep, and now Tomek reacts, and this is a very nice way to activate the patients that are not able to sit, as many of our neurological patients. So, half an hour, it's not a big time, but I hope this gives you just the idea that maybe trying to get a little bit more profound with PNF would be beneficial, because in my opinion, and not only in my opinion, it's a contemporary concept really well suited to help neurological patients. Please remember, no matter where you will be learning, no matter what you will be reading, that philosophy, basic principles, and techniques are the three pillars of the concept. And there is much more to the philosophy and basic principles and techniques. We just really were on the top of it. PNF therapist observes the reaction of the patient. So very often we have to have adaptations. Maybe increase or decrease the resistance, maybe adapt the grip, maybe change the other tools in the basic principles and procedures, or other, maybe change the technique, maybe change the pattern, maybe change the position. These are the things that really should be considered. And last but not least, stay positive. Think about what is strong, not what is wrong. in your patients and really use their strengths to improve their weaknesses. Even a tetraplegic patient has strong parts, believe me. Thank you very much for your attention. You can see my email if you have any questions, if you need reference for the topic that we covered. I'm really happy to answer your questions. And thank you that I could be, Dr. Manish, that I could be a part of Scientifica this year.
Thank you so much, sir. Thank you so much. This was a session beautifully blend with the practical demos, I would say. Uh,
Yes.
so we have a question for you, sir. There was a lot, we can see a nice lumbrical grip everywhere
Yes.
where you were practicing. So now, can you tell me that when you were teaching the functional activities to the patient, direct and indirect way,
Mm-hmm.
so how do you decide that how to reduce the handling of the patient and shift the patient from manual resistance to environmental resistance more?
Okay, so thank you for your question, Dr. Manish. Uh, Again, I said that we need to observe the patient. So I start with the task activity and I say, okay, can you grab the cup? Can you try to reach for the end of the mat? And if the patient is able to do it, then I'm thinking, okay, can I add resistance so the patient can be stronger? Or should I help him to reach this end of the mat because he's too weak?
Mhm.
Um, so it depends on the action of the patient. And very often my resistance is also not only to strengthen, but also the resistance, the guidance resistance. So if the patients feel where he is resisted, he knows where he or she should move.
Okay, thank you so much, sir, for that beautiful session. And I thank you for taking your valuable time out for us and giving us so much about PNF for treating a neurological patient. I hope
Thank
the
you.
audience is also content with the session.
Thank you very much. And it was not that much time. I would like to really be with you more, and hopefully it will happen someday.
We would love to have you in person, sir. Thank you so much for having accepted our invitation. Thank you, sir. Thank you so
Stay
much.
positive. Bye.
Bye bye.